Hi, so I'm Rosie Bradley. I'm a statistician here in CTSU within the University of Oxford, and I'm here on behalf of the Early Breast Cancer Trialist Collaborative Group. And I'm going to talk to you today about the treatment of early breast cancer in postmenopausal women. So the EBC-TCG started in 1985. It was established by Richard Peto and set up in CTSU. It's an ongoing international collaboration between hundreds of trial groups showing individual patient data, which is held here in Oxford, for meta-analyses. Meta-analyses combine data from several trials to view the totality of the evidence. So across the world, we have over 95% of all the trials that were conducted in early breast cancer. We aim to assess the long-term effects of various treatments for early breast cancer, where survival is our primary endpoint. We hope to do this more reliably than any individual trial can do alone. I'll be presenting some of the key results published by the collaboration over the last 5 years. And I'm going to start by showing the main results of tamoxifen for 5 years versus not, published in The Lancet in 2011. So here I'm focusing on postmenopausal ER-positive women. Tamoxifen works in all ages but has no effect in ER-negative. So the graphs I'm showing are for recurrence, split by ages 55 to 69 and 70 plus. Along the bottom of the graph we have years since diagnosis, and the vertical axis is the percent of women who've had a recurrence. I am going to focus on the absolute differences between the treatments for this talk. So in the first 5 years when treatments are being given, for the control arm, so they received no tamoxifen treatment, 30% of them will have had a recurrence at 5 years, compared to 15% in the tamoxifen arm. Extending this out to 10 years, we can see that the control group, 43% of them will have had a recurrence at 10 years, compared to 26% in the tamoxifen arm, showing a highly significant result. In the age 70 plus, we can see similar patterns in the graphs. So in the first 5 years when treatment's being given, in the control arm where there's no tamoxifen treatment, 30% will have had a recurrence compared to 16% in the tamoxifen arm. Extending that out to 10 years, we can see in the control arm, around 46% will have had a recurrence at 10 years compared to 24% in the tamoxifen arm, again showing a significant difference. So in both these graphs, the treatment is being taken in the first 5 years, and when treatments are stopped, we're still seeing benefits from these treatments nearly 5 years later. So the next meta-analysis results I'm going to show you are from the aromatase inhibitor versus tamoxifen. This was published in The Lancet in 2015, and the whole meta-analysis included around 32,000 postmenopausal ER-positive women. I'm going to focus on the results which had the trials of the aromatase inhibitor for 5 years versus tamoxifen for 5 years. There's around 22,000 women in these trials. So the graphs I'm going to be showing are for recurrence and breast cancer mortality. So taking the first 5 years again, when the treatments are given, in the tamoxifen arm, around 12% will have had a recurrence at 5 years, compared to 9% in the aromatase inhibitor arm. Extending it out to 10 years, in the tamoxifen group, around 23% will have had a recurrence, compared to 19% in the aromatase inhibitor group. This is showing a highly significant difference for recurrence. For the breast cancer mortality, in the first 5 years when the treatments are given, for the tamoxifen group, around 6% will have died from breast cancer, compared to about 5% in the aromatase inhibitor arm. Extending it out to 10 years, we can see that 14% of the tamoxifen group will have died from breast cancer causes, compared to 12% in the aromatase inhibitor arm, again showing a significant difference. I know these graphs don't look as striking as the tamoxifen graphs I've previously shown, but this is showing that aromatase inhibitors are even more effective than those tamoxifen treatments. So small improvements are adding up to big improvements in recurrence and survival. So here I've taken the previous recurrence graph and I have split it by age 55 to 69 and 70 plus. We've got 5,660 women over the age of 70 randomised into these trials, and these graphs are showing that aromatase inhibitors are effective for the younger postmenopausal group and both the older postmenopausal group. So the main conclusions of the paper were that aromatase inhibitors are even more effective than tamoxifen in preventing recurrence and breast cancer death. Taking 5 years of an aromatase inhibitor reduces 10-year breast cancer mortality by at least 2/5 compared to no endocrine treatment. There's no differences in non-breast cancer mortality, but there are more bone fractures with aromatase inhibitors, which leads nicely onto our next meta-analysis of the bisphosphonates, which was published in The Lancet in 2015. So bisphosphonates are usually used to treat women with osteoporosis, but they have shown, the treatment has shown signs that it can modify the process of metastases. Individual randomized controlled trials couldn't produce a conclusion of this. So we've put together a data for our meta-analysis, which included around 19,000 women in trials of 2 to 5 years of bisphosphonate versus control. Here, we're showing the results for around 12,000 postmenopausal women for bone recurrence and breast cancer mortality. So, for bone recurrence, at 10 years, the group who took no bisphosphonate treatment, around 9% of them would have had a bone recurrence, compared with around 7% who took the bisphosphonate treatment would have bone recurrence at 10 years. This is showing a significant difference between these two treatments. For the breast cancer mortality, the group who took no bisphosphonate treatment, around 18% of them would have died from breast cancer at 10 years, compared to around 15% who took the bisphosphonate treatment. Again, it's showing a significant difference between the two. So again, this is showing even after treatments are stopping during these first 5 years, we're still seeing effects of the treatment 5 years later. In these bisphosphonate trials, there was around 1,000 women over the age of 70 who were randomised. So the main conclusions of the paper were we saw fewer bone recurrences, benefits appear confined to postmenopausal or older women, and there have been fewer bone fractures. So this meta-analysis shows that adding further agents, we can improve survival further. Some of you would have seen in the news last week, there was a press release about bisphosphonates. So Breast Cancer Now released the results of a poll which involved responses from 125 cancer specialists, and it found that 59% of them had not brought in bisphosphonates for their breast cancer patients, 24% of them had introduced them, and 17% had partially introduced them. Moving on to look at chemotherapy in older women. So I've decided to show anthracycline as an example, but we see similar patterns in other chemotherapy regimens. So this graph is for recurrence split by ages 55 to 69 and 70 plus. We can see that the anthracycline is reducing the number of patients who have a recurrence, but in the age 70 plus, we've only got about 350 women randomised. So we've gone from seeing relatively large numbers of older women over 70 randomised into the endocrine trials to very few randomised in the chemotherapy trials. So currently we are unsure of what chemotherapy regimen is most suitable for the over 70s. So we do need more older women in breast cancer trials to find the answers to questions like these. I wanted to finish off by showing you the breast cancer mortality from 1950s through to 2015 at the ages 35 to 69 in the UK and the USA. So risks have halved from the 1990s to 2015, with the UK showing the biggest drop worldwide from 2.4% down to 1.2%, and the US 1.9% down to 1.1%. And these risks are still falling. So we've seen a large effect in the UK and the USA on breast cancer mortality by combining several moderate effects. There's earlier detection of breast cancer, earlier treatment, more reliable treatments, but there's still moderate effects are still worthwhile and achievable. The EBCTCG future collaborations aim to find more effective chemotherapy for postmenopausal women.